a bit of a experienced a bit of a delay. My name is Stegling. I'm the Executive Director of Frontline AIDS, and I'm really happy to welcome you all this morning, I hope it is morning where you are, to this really exciting conversation under the title Prevention Now, Ending New HIV Infections in the Time of COVID-19. I'm really excited. I have an amazing panel of friends and colleagues who are going to have this conversation. I will introduce them in a minute. But before I do that, I just wanted to thank all of you for joining us. Also wanted to let you know that this is obviously a Zoom webinar, which is hosted in the webinar function, which means that all the attendees' microphones have been disabled. So later you will be able to submit questions in the question and answer function, and you can comment in the chat box. So we have several members from the team who are going to monitor the chat box and also the question and answer function. So just to say right from the beginning, this is, we are attempting, and we already had a glitch, so hopefully this will be the only glitch of the morning. We're really attempting for this to be a very interactive space. We will start by seeing a video message from the UNAIDS ED. And after that, I will introduce our panelists, and then I will try the best I can to pretend that we're all sitting in the same space and that we're having a conversation rather than very long speeches by people, because I do know everyone on the panel has lots of good things to say, and I would really like us to have a conversation. We know conferences tend to be the places where we have to listen to very long speeches by people. So we decided this was a PowerPoint free space, and that this is really about us having a conversation. And as I say, I'm very much looking forward to this. We will review the question and answer in the chat function throughout. And so any questions and comments will be flagged to me. And obviously for participants, if your question is a particular, or your comment is to a particular panelist, please note that in your comment. And we will be recording the event, and so we can share the recording with participants 24 hours after the event, and I hope everybody is happy with the recording. I will pause now. I hope everybody that wants to join is now on the webinar, and I will start by introducing a short video message from Winnie Byanyima, who was appointed as the Executive Director of UNAIDS last November, and many of us have been working with her quite extensively since then, and especially to make sure that prevention keeps very high on her agenda as she steps into this role and leading the joint UNAIDS program. So we asked Winnie to join us with the video. And as many of you know, before Winnie joined UNAIDS, she was the Executive Director of Oxfam International from 2013 to 2019. Without further ado, I will hand over to Winnie and her video message, and we'll take it from there. So please go ahead, Olin, with the video.
So Chrissy, can you see this video now?
I can see a screen, yes.
Hello friends, my name is Winnie Byanyima. I lead the UN Global Response on HIV. Thank you for inviting me to speak at your flagship event. I'm very concerned about the colliding epidemics of HIV and COVID-19, especially because even before COVID-19 struck, we were not on track to meet the global HIV prevention targets for 2020. Now COVID crisis risks blowing us way off course. The AIDS pandemic remains a global crisis fueled by inequalities, but the urgency associated with the response is waning and millions are being left behind. That worries me. We have not reduced the number of new HIV infections at the rate we committed to. Last year, there were 1.7 million new HIV infections, and every single one of these could have been prevented. Denied their right to health, marginalized groups such as gay men, sex workers, transgender people, people who inject drugs and their partners, they make up over half of all new adult infections. Every day, these groups don't get the health care they need, they are criminalized and they are marginalized. Meanwhile, women and girls are too often denied their sexual and reproductive health and rights, and gender-based violence and inequalities continue to drive the epidemic. Across sub-Saharan Africa, young women and girls face rates of HIV far higher than men and boys of the same age. We should be outraged because we have the evidence, the tools, and the commitments to prevent every new infection. But we are clearly not reaching people with the services they need. COVID-19 is seriously disrupting HIV prevention and support services for key and vulnerable populations. Lockdowns are hurting the poorest the most and increasing vulnerability. And we are seeing an increase in marginalization and abuse of human rights. This makes our prevention work even more urgent. In at least 1 in 4 countries reporting to us, prevention of mother-to-child transmission services have been disrupted. To put this in context, if prevention of mother-to-child transmission services are disrupted for 6 months, our models show that this could lead to an increase in new HIV infections in babies by as much as 83% in Mozambique, 106% in Zimbabwe, and 139% in Uganda. This alone would reverse all the progress over the past 10 years in preventing new infection among newborns. COVID-19 lockdowns are having a terrible impact on women and girls and key populations. Sex workers, transgender people, people who use drugs, and gay men have lost livelihoods and face violence. They are also denied social protection many times. They are scapegoated as the transmitters of COVID-19. Our country offices are reporting disruptions in support services for key populations. In short, the crisis in HIV prevention is being made worse by COVID-19. But we cannot focus on just HIV or just COVID. That's a false dichotomy. We must do both. The right to health means that no one disease should be fought at the expense of the other, and we cannot divert investment from HIV and other diseases. Any reduction in resources for HIV prevention in the face of COVID will only make the current HIV prevention crisis worse. COVID-19 is a new crisis requiring new, not reallocated resources. It requires renewed energy and robust leadership. What we desperately need is a different politics to guarantee the right to health of everyone, everywhere. Closing the prevention gap means dismantling injustices and inequalities which put young women and girls, gay men, sex workers, transgender people, people who use drugs, prisoners and migrants at great risk of being infected with HIV. Prevention services must be considered essential services during the COVID response and lockdowns, particularly the commodities and support services that vulnerable groups rely on. We need to reach population groups and locations with the highest rates of new infections with prevention options that work for them, how in the way they live their lives. We must reach people with what they need where they are, from delivering prevention commodities through community service points to expanding the use of virtual peer platforms to rolling out HIV self-testing. And it's absolutely critical that we mobilize the investments we need for effective prevention, even in the midst of another pandemic. One last word. I want to recognize the critical role of civil society and responses led by and for the community. You've always played a central role in raising awareness, providing information, dispelling myths, and you've led the way when it comes to connecting key and vulnerable populations with services. Now more than ever, community leaders should be supported to deliver and should be recognized and resourced as essential service providers for both HIV and the COVID response. Resilient health systems rely on communities. We need you. We need you for HIV and for COVID and for the next health crisis. I thank you.
Thank you. And thank you, Lilian, for sharing this. So for those of you who joined us a little bit later, this was a pre-recorded message, very obviously, from Winnie to set us off. And I want to thank her and colleagues at UNAIDS for making this happen. Unfortunately, Winnie couldn't be here in person. As we know, this is the start of the AIDS conference. And even though we're virtually, everybody's trying to be in 100 different places at the same time. So, you know, just to kind of make a connection between what Winnie says and to our discussion this morning, which is obviously around really trying to dismantle about what we need to do around prevention in the face of yet another pandemic. And Winnie very clearly saying there is a false dichotomy if we try to think about HIV, the HIV epidemic versus COVID-19 as an epidemic. We need to address both of these epidemics together, and very scarily, you know, the modeling that shows us if we don't do that, how far back we will go and how much we will lose of the progress we have made over the last couple of decades. So we all know that the new UNAIDS figures will come out today, will be launched today, and we all know that what is going to be presented is not a nice, is not an encouraging picture. And we all need to be very alert to that and think about what that means for our work, for UNAIDS's work, but also the broader global response to HIV prevention. My interest in what Winnie said is really around the need for different politics. I think I can't agree more with her that we know what we need to do technically to respond to HIV prevention, how to prevent new infections. But what we don't know, or what we haven't tackled enough, is how we create a different type of politics that really guarantees the right to health for everyone, everywhere. And it would be good to have more of that conversation as we are moving into the conversation this morning. Obviously, wonderful to hear that resilient health systems rely on communities and civil society, and how we all play a critical role as civil society and as community leaders to ensure that both HIV and COVID-19 will be addressed. And as Winnie says, we need you now, but we also need you for the next health crisis. So investment into community systems is a sustainable investment for as a central part of investing into health systems. Obviously, you know, many of the speakers this morning will talk about how they have adjusted and their own responses. We see very much as Frontline AIDS, what's happening at country level is that prevention services are severely impacted. And as Winnie noted, there is a secondary epidemic, which is the epidemic of lockdowns and the economic and human rights impacts that those lockdowns are having on especially the most marginalized communities. And I'm hoping that some of our speakers will also speak to that. So it is vital at this point that we are vital to sustain, but also to scale up progress on HIV prevention, because we know we have failed to reach our targets in 2020. And this is kind of the conversation that we want to have this morning with my esteemed panel. So I will move into introducing my panel. I'm really happy because many of you are good friends and very cherished colleagues that many of us have worked with for a long time. I'm going to introduce you one by one, just with a couple of sentences, and I will invite you, each one of you, to say just one or two sentences why you're excited to being here this morning and participating in this conversation. So I'll start with Paula, Dr. Paula Munderi. Paula is the coordinator of the Global Prevention Coalition, and she leads on prevention at UNAIDS and joined not even that long ago, maybe a year ago now, Paula. You can speak to that. Before that, Paula worked for the International Association of Providers of AIDS Care, IAPAC, and also worked as a clinical researcher at the Uganda Virus Research Institute. And Paula is from Uganda. So Paula, why are you happy to join us this morning? Just remember to unmute yourself when you speak.
Thank you, Christine. It's been 6 months at UNAIDS. Okay. I'm excited to be here, especially this session led by Frontline AIDS, and as a testament to the importance of community-led platforms in pushing the agenda of prevention going forward.
Great, thank you, Paula. Welcome to the conversation. My next panelist is Dr. Gina Dallabetta. Gina is a senior program officer at the Bill and Melinda Gates Foundation in the delivery section of the HIV/TB program. Gina currently manages a portfolio of investments in HIV prevention research and implementation. And prior to the Gates Foundation, which she joined in 2005, she worked for what is now FHI 360. And we have a long relationship as Frontline AIDS working together on the Prevention Coalition. So Gina, just a couple of sentences about why, first of all, welcome, and maybe just a couple of sentences about why you're excited to join us this morning.
Thanks, Christine. So yes, I'm excited to be here because prevention is my passion. It's been my life's work. So I'm more than happy to talk about it. And I think it's critical that we keep it on the front burner.
Great, thank you, Gina. We are also joined by Ed Nkosin. I hope I'm saying that right. I've just realized, knowing Ed for so many years, I've never known how to properly say his surname. Ed is the technical advisor on key populations from the Community Rights and Gender Department at the Global Fund. His role is to coordinate the work on key populations across the Global Fund. And previously he worked with a number of community-led networks and organizations at global, regional, national levels on the issues related to people living with HIV, KPs, and young people. So welcome, Ed, and why are you happy to join us this morning?
Thank you so much, Chrissy, and you can just call me Ed without the surname. So I'm particularly very excited to join a panel of distinguished colleagues and friends to highlight this urgency, because I think we can't be complacent, as Winnie said. The impact of COVID on the disruption of HIV service is pretty real. But most importantly, I think I'm very excited to be able to share and learn from all of you as how we as a global community can turn this crisis into an opportunity and use that to really catalyze and reframe, re-energize the response to HIV prevention. Thank you.
Thanks, Ed. And I think we will get back to that question of, is there an opportunity in all of that? So a really interesting question. My next guest is Lilian. I hope Lilian's camera is on. Yeah, she is. Dr. Lilian Otiso. Lilian is the Executive Director of LVCT Health in Kenya. She oversees over 200 staff implementing LVCT's health program, which includes major programs funded by PEPFAR and the Global Fund on prevention, HIV testing and counseling, care and treatment, and sexual and reproductive health and rights and gender-based violence. Welcome, Lilian. We're very happy to have you. Maybe just a sentence or two about why you were excited to be with us this morning.
Thanks, Christine. I'm excited because I and LVCT Health have been involved in HIV prevention and response work for a long time, and really targeting the populations that are most affected by HIV and also by COVID. So I'm hoping to be able to benefit and also share what we have learned about HIV prevention and keep that conversation going even as the COVID disruption has taken place or is taking place. Thanks.
Wonderful, and really nice having you here, Lilian. And the next person on to introduce is Abhina Aher. Abhina is the Associate Director on the Gender, Sexuality and Rights Project at Alliance India, a good friend and somebody we work with a lot at Frontline AIDS. Abhina works particularly with key populations, including men who have sex with men, transgender women, and women in sex work. Abhina is a trans activist. She has been working in the HIV sector for the last 24 years, providing technical guidance and support to WHO and the National AIDS Control Society in India. Welcome, Abhina, and a couple of words about why you are happy to be here.
Thank you, Chrissy. I think one of the important part that I must highlight is that the theme of AIDS 2020 is about resilience. Today I'm here because community demonstrate resilience. Community showcase that, you know, in acute difficult situations, also community stands together to respond to epidemics such as HIV. Winnie already spoke about how we were not in line with on our track, specifically on HIV. Right now, it is really important to come back on track with the current situations. In fact, we have to step up with current objectives and targets that we have. So we need to have work double, triple together, and the responsibility lies shared together. That's the reason why I'm here to share my responsibility and contribute to this webinar. Thank you so much for giving me an opportunity.
Great, it's lovely having you, Abhina. And last but not least is Madiarra, Dr. Madiarra Coulibaly. Madiarra is the Executive Director of Alliance Cote d'Ivoire, which managed the Global Fund, has managed the Global Fund grant as a principal recipient in Cote d'Ivoire for the past 10 years. She has worked in HIV for the past 20 years, working on the first PMTCT pilot projects, the development of prison health policy, gender mainstreaming in the response to AIDS and HIV prevention among key populations in Cote d'Ivoire. And I want to say a special thanks to Madiarra for agreeing to speak to all of us in English. If we were in a different place, we would hopefully have somebody to translate, but I just want to acknowledge that some of us make extra sacrifices to have conversations in English when we would be much more comfortable in a different language. So welcome, Madiarra, and please just let us know why you are happy to be here. And your camera is off. I don't know if that is on purpose.
Hi, morning, everybody. I'm very excited to be with you because I know Frontline AIDS have a real engagement on prevention. And so in our partnership for us is very important to see how we can learn from each other to see how to strengthen the prevention in our context. We know that in West and Central Africa, we have many gaps in prevention targets. And so the context of COVID-19 come also as a real issue for us. So being here with the other panelists is an opportunity for us to learn from them. Thank you.
Wonderful, and keep your camera on, Madiarra, because you're going to be my first person to ask a question to now. Thank you very much, all of you. It is exciting to have you all here. You're really an esteemed panel, and I think there's a nice balance between people working at the global level, people working at country level, and people working in particularly with particular key population groups at country level. So I think we're well set up to have an exciting conversation. So my first question is broadly along the lines of, you know, we knew that there was an HIV prevention crisis even before COVID-19 arrived. But even if COVID-19 wasn't there, let's maybe step back a moment and ask ourselves, what has driven that prevention crisis that we experienced in the different countries? So I want to start with Madiarra. In Cote d'Ivoire, the latest estimates tell us that HIV infections in the last 10 years in Cote d'Ivoire have reduced by only 27%, instead of the target of 75%. What do you think, Madiarra, are the reasons for this lack of progress in Cote d'Ivoire?
Thank you, Christine. So it's true that the target, the global target of prevention has not been reached in my country, but we can consider that progress has been done when we compare the rate of 54% with the reduction rate of new infection in the world and in West and Central Africa, which are 16 and 12% from 2010 to 2018. However, efforts still need to be done in several areas of prevention in my country, in particular in mother to child transmission. The rate of the transmission for mother to child still high, around 10.9%. And the stigma and discrimination of people living with HIV still remain high, around 40%, and according to the whole stigma index we made. We are awaiting data from the new ongoing stigma index study, which will include stigma toward key population as well. Even if efforts are made to ensure services, the fear of stigma still remain a barrier to access and to use them. So it is also difficult for certain population to access to prevention services. So in our activities, we require specific approach, in particular for men over 25-year-old, for whom we develop the multi-diseases approach just to reach them. For the young girl also, we are with a partnership with Frontline AIDS, develop a ready approach to target them. And for key population, we set up several approach as a night clinical drop-in center, conviviality session for them. So we need also to strengthen efforts on application of innovation measures such as PrEP and self-testing, which are still in the pilot phase in my country. And we need also to set up innovation in communication on HIV/AIDS by adapting our message on HIV/AIDS and by refreshing the message on HIV/AIDS. For example, the UNU campaign could be beneficial in our context, because we are in the population, the whole idea, the whole perception on HIV/AIDS, and for us it's important for them to change the mindset on HIV. Finally, we have the issue of coordination of the donor and the implementer partners, and also the issue of financing the prevention in our context. Many efforts have been done on treatment, but when we have a concern on financial, is the prevention issue was left behind. So for us, it's important to work on it, to make advocacy, to ensure that everyone in the country can get the good message on HIV/AIDS.
Thank you, Madiarra, and really disheartening to hear about PMTCT rates still being almost 11% in Cote d'Ivoire, and listening to Winnie's message, you know, we might just be stepping into a much bigger crisis around PMTCT that we thought we had long kind of, at least that wasn't the biggest one of our problems in prevention. You spoke about many of the things we can all get back to in later conversations, the importance of innovations, but also you know, stigma and discrimination being such a big issue in your region still. So thank you for sharing that with us. Lilian, let me move to you in Kenya. In Kenya, again, latest estimates show that the number of new HIV infections amongst adolescent girls and young women between 15 and 24 has only decreased by 20% since 2010. Again, what are the issues that are holding us back for reaching better numbers with reducing HIV infections?
Okay, thanks for that. We've seen that in Kenya, there have been overall reduction in new infections, but not among this population. And some of the reasons have been some reasons that we've known for a while, but nothing much has changed. One of them being poverty and economic concerns. So that makes a lot of the adolescent girls and young women engage in transactional sex, where they would engage in that for basic requirements, including pads, which have really come up as a big need in country. A lot of the girls are forced to drop out of school, either due to poverty, their parents not paying fees, and that leads them into a cycle of poverty where again, they will engage in sex or get pregnant and then keep having to be put themselves at increased risk. Another major issue is the lack of information on sexual reproductive health. And this has remained and is still a very pertinent issue and very controversial in the country. We have extensive opposition to comprehensive sexuality education from religious and other groups in country. And unfortunately, it encompasses even basic information about just knowing the risks of HIV or unwanted pregnancies and abortion. So it's a holistic idea of let's not talk about sex to people who are still in school, yet when we've had sessions and outreach activities and even our hotline where young people call, a lot of them would want to know more about sex, how to prevent themselves from unwanted sex and dealing with issues of abstinence or coercion versus consent. So there's a lot of information needs from the young people, but there's no information available. It's not in school curriculums and it's really limited. Most parents don't know what to do about it, don't know how to talk about it, and our research has also shown that. So we hope that that is one area that can really change. Most information comes from peers, so we know peer models work, and that's another aspect that can be built upon, except for, again, the restrictions on that. Then now, finally, the other key area I want to highlight is just lack of services that are suitable for adolescents and young people to access the services. We've been talking about adolescent-friendly youth services or youth-friendly services, but we still don't know clearly what that means. It's not well defined or understood, and therefore the young people are forced to keep accessing services in the regular facilities. And we know through that, because they feel the health workers are not treating them with respect, they don't feel comfortable and don't go there. And in addition, there's lack of legislation that allows healthcare workers to provide reproductive health services like condoms or family planning to those who are less than 18 years. And this is one of the most controversial issues. So it means that the adolescent may go there and ask for services, but they will be denied those because of consent and their age and that legislation. So we know that that's a big problem that we need to tackle moving forward.
And so kind of, you know, you think like we have had this conversation for so many years and we're still talking about the same things. And I think this is when we need to speak about different politics of prevention, right? It's not that we don't know what to do, it's just we're unable to do it. And then obviously interesting to talk about poverty and the impact of poverty and how that will play out now, especially with COVID-19 and the secondary impact of that. Thank you, Lilian. I'm going to move to Abhina and ask you, Abhina, in India, most new infections are monkey populations, including people who use drugs, sex workers, and men who have sex with men, and transgender people. Why do these populations continue to be left behind in India?
Thank you for your question, Chrissy. I think one of the important thing that we must understand is that as the global scenario on HIV is changing rapidly, and there are responses which has been driven, we still yet to figure out a balance between prevention and care and support. There are many times care and support has been considered as a prevention, and prevention has been considered not been given an importance within within the countries like India. So in countries like India, there is a continued response. There is continued HIV vulnerabilities towards the high risk population because of several things. One is the absence of data and mapping. You know, there is obscure data and mapping, what you need to understand. And this is like a chicken and egg situation. Because you are trapped into a cyclical vicious circle of the prevention, where you don't have enough data, you don't have enough research, and your response is poor. So you are just investing money because the sake of you are investing the money, but it is not going to the real problem that needs to be reached out to. The other thing is that there are so many responses which are available, global reports like UNAIDS gap report, and various report on prevention report that Frontline AIDS has arrived. But you know, there is a dismissal within the countries on these reports. So it happens globally, but it is not happening in our country. So you know, accepting that report and imbibing that report is not happening enough, which requires to that. We still are struggling with the huge amount of stigma and discrimination. I have always been saying this to people, is that policies don't change mindset of people, and that is what exactly is happening. We have managed to get rid of section 377. We have got the transgender acknowledgement. Still stigma and reduction has not reduced for transgender people, and there is a multi-layered stigma. It's like a stigma onion. You peel one layer and then there is another layer of stigma which is already there. I'm a trans person, I'm living with HIV, I'm a sex worker, I may be married to a cis woman for various other reasons, and that is not been dealt within the program. The program is extremely vertical, it is not extremely horizontal, it is not dynamic as the prevention responses has to be there. The other thing what you need to understand is that previously the HIV vulnerabilities which were there within the urban cities, Christine, that has now moved to the rural and semi-urban area. So there is no other difference. It is actually erupting like a generalized epidemic in the perspective, and because there is no mapping and evidence which is required for that, there is a delayed response on reaching out to those areas and providing the essential services which is not being provided. There's a lack of political commitment that you see it across when it comes to handling HIV related work, because when you talk about vulnerable communities and when you keep other people in the same platform, of course your priority goes to women and children compared to the high risk groups, because society do not want them as a part of that. The other thing I must highlight about it, that previously there was a watertight compartment about the communities. Now they are not. It is all merged together. So like for example, we are talking about people who are using drugs, and now we are talking about transgender using drugs. We are talking about sex workers using drugs. We are talking about MSM using drugs. So it is not more anymore specifically as an identity crisis only, but it has actually moved in crisscross on various aspects. So we need to have a dynamic program to respond to that. Having a singular program that is supposed to be designed similarly for everybody will not be able to work together. The last 2 points I want to talk about is that we still have we still not tackling about the structural issues which are affecting to the long-term health-seeking behavior, healthcare stigma, gender-based violence, which is a huge amount of problem which is affecting to a lot of high-risk communities. And many of the times the communities are criminalized, and you are seeing new infections within the jails. Jails is a new thing which is happening, inmates and jails, and there's a huge amount of there's a problem about ARV medications and services and all those kind of things. So these all things are keeping the infections rate still higher within countries like India, though we have progressed a lot, and we are still reluctant to jump on the jump on the modern mechanisms like PrEP, self-testing. We are still contemplating for years about this. We are still not starting this essential things. I'll stop here.
Thanks, Abhina. And I think really lots of interesting stuff. And I hope that people, when you speak later, the other speakers also respond to some of the issues that your fellow panelists have raised. So especially, you know, Abhina is saying at country level, a lot of the global reports are being dismissed because they're not, you know, politicians or policymakers don't feel that they're coming from their own context. The issue of data, which keeps on coming up, and then really interesting, you know, around multi-dimensional identities and how we reflect that in our programming and the call for dynamic programming. So I hope all of my other panelists will come back to those issues. I want to move on to Paula now and really ask our, you know, start a second round of questions around the impact of COVID-19 and the risk for HIV prevention. And several of the speakers have already alluded to what those risks might be. But Paula, from your perspective, you know, sitting at the global level, how concerned are you about the impact that COVID-19 will have on the number of new HIV infections? What threats does prevention face, and what role can the Global Prevention Coalition play in mitigating these threats? Paula, you are on mute. You have to unmute yourself. Sorry. It needs to happen at least a couple of times in the webinar. So there we go. So start afresh.
Thank you, Christine. Very concerned, very concerned. And Winnie has already alluded to the institutional concern that COVID-19 is poised to send us all the way back in our modest, whatever modest progress we've made in the prevention response. So firstly, right at the beginning of the COVID pandemic, we realized that there were going to be probably shortages of commodities and services. So for example, a key prevention service like voluntary male medical circumcision, those programs had to halt because they required large public gatherings. But some countries have also reported condom stockouts and difficulties in distributing condoms. Certainly services that require people to go to a health service like HIV self-testing and PrEP were in jeopardy. Most importantly, the support services on which vulnerable people rely to maintain compliance with prevention interventions. So commodities and services were a concern, disruption in those as a result of COVID. But the response to the COVID epidemic as well scared me. I think the first time I saw law enforcement on the streets enforcing lockdowns, I had goosebumps, because the enforcement of lockdowns also brings about, throws us back to places of discrimination and stigma that we in the HIV control world are very familiar with. The economic downturns as a result of the COVID pandemic are also going to increase vulnerabilities in terms of transactional sex, or just the poverty-related vulnerability to HIV that other speakers have spoken about. And I've mentioned my deep concern about violence. In fact, we have had reports about increasing cases of gender-based violence in homes, violence outside the homes during the course of the COVID response. So all of this is really, all of these are things that are happening and that stand to set us back. What the GPC Secretariat is doing, and you as Frontline AIDS have also been part of this because you participate in the Global Prevention Working Group, was we put out a brief very early on about the two epidemics, about the effect of the response to COVID on HIV prevention services, and giving some advice on what adaptive responses countries could make. These briefs were very well received. We are still in the process of disseminating them as widely as possible. We're also documenting to the extent possible what these disruptions are. So country by country, what disruptions in prevention services have been experienced, with a view to finding where the gaps are and where countries could prioritize in their responses. And as you heard in the opening speech, we are engaged in some very high level political advocacy to maintain as essential the prevention services. Needless to say, an initial concern, and quite rightly so, in terms of HIV control, was a concern about disruption in HIV treatment commodities. But we're also, at every chance we get, saying, well, in addition to maintaining uninterrupted access to treatment, to antiretroviral medicines, it is important to maintain access to prevention commodities and prevention support services as essential services. I think I'll leave it there. And like I said, the continued political advocacy. At the Secretariat, we have a COVID task team that meets very regularly, actually on a weekly basis, getting feedback from the regions and countries that are reporting to UNAIDS. And another thing that this helps to serve is to see what adaptive responses are being seen in different contexts, and also sharing best practices and good practices in adapting to the COVID response.
Thank you, Paula. I think it will be interesting maybe later in the discussion, when we have time, to really go back to this question around changing the politics of prevention, right? Knowing, as you say, we are all very concerned about what the impact we are seeing on prevention services and commodities. And if we lack political will on prevention beforehand, now it's the question, how will we sustain it or even fire it up at a time when many politicians will have to make very difficult decisions around where to put their resources, right? But we'll come back to that. So Gina and Ed, I'll start with Gina maybe. In this context, we know that funding for HIV prevention is already very stretched, and every one of the speakers so far has spoken about that. Many countries are relying on donors to funding for most of their response, especially when it comes to key populations. And the question is, in what ways will COVID-19 impact on donor finances and priorities? What are your organizations, in this case, if I start with Gina, what is Gates doing to address these funding challenges? And what should the Global Prevention Coalition and all prevention advocates be doing to position HIV as a continued priority for future donor funding in a situation where we know donor funding will be really squeezed? So I start with Gina, but we'll come with the same question to you, Ed, in a minute. Go ahead, Gina, please unmute.
Thanks, Christine, and hello, everyone. By way of background, the Gates Foundation is not a donor organization in the typical way that the Global Fund is. And so we view our role as collecting data, collecting information to advocate for how donors spend their money. So we advocate to the Global Fund, and through our advocacy organizations advocate with other donors for, say, replenishment, for example, for the Global Fund. So we are keenly aware of COVID and COVID's potential impacts on HIV and HIV prevention. So we, along with UNAIDS, are trying to monitor impacts and trying to understand where best practices are and where we can intervene. So I think we are in a position where We have a new disease, COVID, that needs to be responded to, and we also have probably a global recession that's going to happen, or because of the lockdowns and all the things that are happening in all countries. So, so I do worry about money for development in general, money for health in general, and as well as HIV/AIDS. And so a lot of it is continued advocacy for investment in health systems and activities within country in general. And then once that's sort of maintained, then kind of what are the priorities in countries that need to be maintained. So it's an issue of modeling, advocacy, collecting data, and this is where I think data is important, because I think it's important that prevention shows some successes. And I know that you know, we talk about data a lot, but I think that until we can show that the investment in prevention actually makes a difference, then it's hard to advocate. So that's why I think data is critically important. The other sort of advocacy that we do and support that we do are really around advocacy around, you know, what kinds of structures need to be in country, advocating for people to be accountable for prevention within countries, to be able to take local data to politicians and say, yes, we're good value for money, we make a difference. So a lot of our role is really advocacy and providing data to the people who make the decisions really about funding.
Thanks, Gina. And I know we're gonna, and Ed wants to speak about opportunities, but obviously there is that frightening moment when we think about a global recession, what will happen to global money for health altogether. And you know, HIV prevention is one small part of that bigger debate. So the question is really about how can we make the right kind of arguments to ensure that people understand it's not just the right thing to do, it's the smart thing to do, because we are really losing the gains that we have made, as much as we still think we could be further ahead in our prevention work. So maybe something to come back to. So maybe the same question to you, Ed, from your perspective at the Global Fund. You know, what is the impact of all of this on donor finances and priorities, and how are you addressing those issues at the Global Fund?
Thank you, Christine. So just to respond to the question, so the COVID really impacts us at every level, the ways we operate, the ways that we support the delivery and monitoring of services, and in many instances, the ability of communities to meaningfully engage in decision-making processes. So I share similar concerns with Gina that the government, our fear is that the government won't honor the commitments to HIV, and that's both in terms of the political and financial commitment. And before the outbreak, as Winnie already mentioned in her introductory video, that we are already far off the prevention targets, and all of us agree that, you know, with the new funding allocation cycle, we need to double down on commitments to advancing HIV response for key populations, particularly on scaling up comprehensive prevention program, supporting community responses and comprehensive human rights programming. And we have been very clear in our messages when we communicate to country back in December how much money they are entitled to apply for. And then COVID came, and then, you know, things get a little bit more complicated, but the survey that we conducted is saying similar thing with what UNAIDS surveys and community surveys are saying, which is 85% of the HIV program suffering some kind of disruptions and 15% reporting high and very high level. And among critical thing is the low threshold HIV prevention services for key populations. So in terms of the priorities, the Global Fund priorities remain unchanged. We have been very clear that pandemic preparedness and global health security must go hand in hand with the sustained political and financial commitments toward addressing HIV, particularly among key populations. And as much as we do care about sustaining the gain on prevention, we also do care about the testing programs, treatment care and support program, as well as addressing human rights and criminalization of those affected. So in terms of how the Global Fund responds, as the funding agency, so we're not a donor, we provide a package of support and additional resources to countries. we moved quite swiftly to support country to respond to COVID-19. And at the beginning of March, we introduced grant flexibilities, which allow for countries to use grant saving and reprogram up to 5% of their allocation to do it. Three things. One is to adapt their HIV, TB, malaria programs. Second is to support their COVID-19 response. And third is to make urgent fixes to health systems and strengthen community systems to prepare for this and the next pandemics. And that made up to $500 million available. In April, we went a little bit further and introducing the COVID-19 response mechanism and making another $500 million available. And at the end of June, as of now, 96 countries and 8 regional grants have access to these mechanisms and investing over 369 million. So resource mobilization aside, with support of partners like the Global Prevention Coalition, which we are a member of, we also develop guidance and tools to support adaptation of service delivery. And that include adapting efforts to address comprehensive human rights programming and working to facilitate some of the good practices and lessons learned across portfolios. And most importantly, I think we leverage existing resources and support for civil society and communities to document concerns and bring voices of communities affected by ways of monitoring the negative impact of COVID and public health measures taken to respond to COVID on the access to health services for key populations. And all of this work is happening at the same time as countries developing their funding requests for the next 3 years. So in terms of some thought on what the prevention advocates and Global Prevention Coalition can do, I think we need to protect and expand prevention services by exactly doing these 4 minimum things. One, aligning with what Abhina said already, that we need prevention programs to be agile and dynamic, and there needs to be a continuity of innovation and adaptation of service delivery for prevention, testing, treatment, and care-related services, so that they speak to the needs of key populations. And this includes, for instance, better documenting practices that deliver impact and capitalizing on the areas I think the uptake has been relatively slow. Similar to the way that we promote multi-month prescription with ART and scaling up self-testing, I think the opportunities here is really to look at the take-home dosages of methadone, make sure dispensing of OST, make sure that it's continued, as well as recommendations around promoting virtual case management approaches for key populations, including for young key populations, and scaling up gender-based violence prevention and response, home delivery of prevention commodity, for example. So there's a range of things that I think we can do now. Second is equally important to continue to monitor access and use it as an opportunity to scale up community-based monitoring and community-led monitoring. And third is to continue to put pressure on government and funding agencies to be more accountable to the commitment. And lastly, I think is to champion and bring urgency to this issue, which I think this is what we are trying to do now on the webinar. Thank you.
Thanks, Ed. And maybe just a quick follow-up question. I think one of the issues that many of us are thinking about is, do you think this is the moment where we just have to declare defeat, that it is very unlikely that governments, national governments, will allocate their own domestic resources, specifically for prevention programs for key populations at a time where they're going to have really dire issues around allocating resources? Should we change the conversation? For so many years, we've been trying to really push and say, it's really important that governments put their own domestic finance in some of those programs to show their commitment and so on. But it almost feels like this is something that, we will speak into black holes at the moment at a time like this. Do you have any view on that?
I think this is a real challenge. As you know, before the COVID crisis, even if the countries are making the commitments to co-financing through their own budgets, the prevention program, sometimes these commitments are not followed through. And I think with the COVID crisis, there's an opportunity to better, as you said, change the narrative around how we talk about prevention and bringing in a different kind of arguments to continue to promote prevention services. It's important equally to demonstrate the short, medium, and longer term impact of prevention service disruption in both countries where we see progress, as well as where the progress is the furthest behind, and include the impact on individual and society from public health, economic, social development perspectives. I think that's what Paula has alluded to continue to push governments to fund prevention. And the last point I think is around really talking about the need to strengthen community systems as a way to deliver services to those most in need. As we know that a COVID crisis is putting a pressure on the health systems, and we try to kind of move people away as much as possible from accessing the mainstream health facilities. I think this is where the community responses become so crucial in this moment, and perhaps a stronger push to really demonstrate the impact of this, well costed, as well as promoting the practices that work and that really reach people with prevention services would be a strong argument to make in this time round. Thank you.
Thanks. Yeah, and I think there is something more when we talk about opportunities, right? There's a moment here where we can speak about really maybe one of the opportunities in all of this is that it's become crystal clear to every government, even in countries like the UK, that you need a functioning health system that includes community health systems, right? And so maybe where we have we stepped a little bit away from that, and I think here's the moment, I think, for all of us in civil society and in communities to keep on making that argument again and again, and how important it will be for prevention. So we'll come back to that. I want to move to Abhina and really move to the third section of our conversation around programming, prevention programming in the context of COVID-19. Abhina, you've already spoken around the national prevention response and how it has been impacted on by COVID-19. And you spoke about the challenges. Maybe you want to speak a little bit more about the challenges that, especially the communities that you work with, MSM, transgender, people who use drugs and harm reduction programs, how they have been affected by this other epidemic. But also importantly, I really liked how Ed started the conversation about that. What are the opportunities? Because we know the situation is dire, but let's try and find what are the opportunities in there as well. So over to you, Abhina.
Thank you, Chrissy. I think some of the things that, so what I wanted to, how I wanted to place it, that there are certain things which has been affecting to all the communities, and there are certain things which are affected to specific communities. So overall, which has been affected situations for the communities has been, one is access to health, which has been affected tremendously. All the services which were provided, and key communities, 85% of HIV prevention in countries like India is through key communities, high risk groups. And we have a huge amount of HIV infections, almost 9% infections among people who inject drugs, 7.4% among transgender women, 4.6% among MSM, and also 2.5% among the women in sex work. So you can understand the HIV epidemic is centric around the things, and these people were living with HIV. They had an issue about accessing services within this particular period. The second thing is about the basic things like poverty and hunger, because a lot of them were actually surviving on a basic minimum amount that they were earning. They were not a high-fi people with a lot of bank balances and come from upper class society. These are the grassroots level of people who are facing struggles in sustaining their shelters as well. So a lot of the landlords asked them to leave their house, and some of them have walked from one state to another barefoot, like 1,200 kilometers, so many spaces that we have seen. A lot of people have committed suicide because they could not survive with their families. A lot of HIV positive people, other people. The other thing is about mental health, because mental health has impacted immensely to our communities, especially during this period, because first of all, high risk communities are very not enough outspoken about their issues to other people, and when they are trapped with their families or the confined settings where they are not supposed to be out and open talking to people. That has impacted their perspective. Migration has impacted big time for high risk communities, because a lot of them were there in some other states, and they could not come back to the states that belong to another related aspects. uh, so now I will just come back to a specific things about how the particular communities have been affected. So like you were talking about harm reduction community, people who inject drugs, and specific things that these people have been impacted with. One is the arrest by the people, because the drugs markets changed overnight, Krisi. Borders are sealed. The prices of the drugs went 600 times higher, which is not affordable by anybody at that point of time. NACO's, National AIDS Control Organization, supply chain has impacted because the borders were sealed. The basic OST, naloxone, buprenorphine, these were the facilities which were not even reaching to the communities which needed to have. A lot of them were arrested into and put into the jail without questioning. They were there on the street, they were trying to buy drugs, and they were just arrested and put inside the jails without any explanations. And as a result of them, access to them for ARV medications and other TB medications and other facilities within the jail setting was a biggest task that we were talking about. Now, the other thing that has happened is basically specifically around when it comes to FSW. With FSW, there were so many issues that have happened, which specifically around SRH issues. So, like for example, the basic necessities that they wanted to buy, buying sanitary pads for them, especially in the because of the menstruation cycles, they have not been able to purchase those basic facilities. Also, a lot of them were pregnant, and they've been denied with the institutional facilities for pregnancy. A lot of them wanted to go for a safe abortion. They could not manage to get these facilities done. Their business is impacted immensely. I don't have to say anything about it. But this is not just a formal sex worker. Believe me, majority of sex work in India is right now transformed because of the digitalizations, and majority of that is happening in virtual spaces. So these women were in virtual spaces. They became subject to the blackmailing also. They became subject to the virtual exploitations also, because they were so desperate to earn the money from their customers. Their customers were demanding anything and everything from them. Send me the nude pictures, send me the videos, nude videos, and I will. And then the customers were actually blackmailing them with that. So gender-based violence, exploitation, gender-based violence from your parents, from your family members, and from your lovers and spouses were very much higher. The biggest issue that happened with these people was the mental health, because they were not used to sit in a confined place, and they were asked to sit in a confined place over the 4 months. They were not been able to deal with this hatred from their own families, and as a result of them, a lot of people were become acute cases of depression. Now, lot of people were also not doing a full-fledged work as a sex work, but they were part of the spas, they were part of the parlors, and all this sex work was happening as supplementary work for them. And spas and parlors were shut down, and it will be shut down for under I don't know how much time, and it has impacted their work as well. When it comes to MSM community, Chrissy, social media bullying increased. So everybody was there on social media. Have being a gay, being MSM was a soft target for everybody. While MSM were trying to reach to other MSM people to talk to them, to have a socialization or create groups, there were a bunch of people who were actually doing hate crimes on the social media. They were just bullying these people. They were just trying to, kind of harassing the people left, right, and center. Mental health issues were other part about that. There are the statistical evidences at the global level, Chrissy, that 40 to 60% of MSM are married to cis women also. And now it become very difficult for them because they have to deal with their wives. So long they were keeping themselves busy with the work, and then in the night probably they were having sexual activity or something. Now they are left at home. They were supposed to have forced sex with their wives without because they don't have anything, and there was this particular demand. So there has been a lot of things that has been reported by them. A lot of MSM were also into sex work, and that has also impacted their work. When it comes to transgender people, the first case among HRGs which was reported who died because of the COVID were transgender person. Because the fact remains is there's a lack of knowledge, lack of acceptance about this can affect us. Because you so desperate that what is the reason that you will choose to die? A corona or a hunger? You know, you would choose hunger, that I want to first work around with hunger and then I will think about corona. As a result of them, the HIV the corona infections has been extremely higher among the transgender people. There were a lot of people who were. The unfortunate part was the quarantine facilities were also binary, Chrissy. There was no specific quarantine facility for transgender people. So where would you keep them? Where would you keep them in this kind of a difficult situation when it comes to, and especially when you are COVID positive and also you're living with HIV? How do you deal with those kind of aspects? So that is those were the certain aspect that I wanted to talk to you about. And also there has been harassment within the hierarchical structures of hijra gharana, which is like a socio-ethnic identity in countries like India, where you have master and disciple. So one transgender person is a daughter of another trans person, and when that daughter is not earning money and sitting at home, even the guru of that trans person was not willing to take care. So these were acute problems that we were talking about. Now coming back to the AIDS situations about opportunities and other things, I just want to highlight
You have
that there are.
be quick now on your opportunity.
Yeah, I'll just talk about opportunities right now. So the opportunities that I see it across is that you have communities who have come together and they are trying to do certain things about it. So you can reach out to the communities, you can involve them into the HIV response and then become part of that. The other part about that, you can create a holistic response. This is a time where you can immediately create, keeping HIV as a centric part and creating a holistic response for the key communities so that their overall health can be managed. This is the time when you can actually strengthen the data and mitigate the gaps regarding to the social welfare of high risk group, because this is where they need support. Right now they are not getting facilities. And last thing is about that, I just think that this is a time for us to also contemplate and develop our efforts on how can how the HIV response becomes more resilient with COVID, without COVID. And I think that is more important at this point of time. I will stop here with the interest of time.
Thank you, Abhina. And it sounds like we could have a whole seminar on just talking about the differential impact on different key population groups. I think you're making such an important point that people keep on talking, you know, even in the country where I live at the moment, in the UK, politicians keep on talking about COVID-19 is the big leveler, like everybody experiences it the same way. And we all know that's not the truth, right? So it's really important to look into, you know, what is the differentiated impact on the different groups, and what does that mean for prevention in the medium term, but also in the long term. And then this really good reminder from you that people have to make really difficult choices between hunger and looking after their health, right? And we all of us see the pictures from India and of people walking for hundreds of millions of miles, which is hundreds of miles, which is really disheartening. So you know, we need to keep on reminding ourselves that's the reality that people are sitting in when we're talking about HIV prevention and preventing of COVID-19. Let me just go with the same question to Madiarra and then to Lilian. You know, what are the challenges that the communities that you work with most, in your case, Madiarra, key populations and adolescent girls, that you're working with or that your organization is facing, and are there any opportunities?
Okay, thank you. With the COVID-19 pandemic, we globally have a distraction from HIV prevention due to the pandemic. So some key process in advocacy we have setting up was delayed. And we noticed also a slowdown in proximity and a mass prevention intervention in the community due to the restriction imposed by the government. And also the masks were not available at the beginning of the pandemic to ensure the protection of the community actors. So it should also be noticed that the curfew and the global fear of COVID-19 in the population have negatively impacted the activities of some key population as sex workers, whose source of income had been reduced. Risk on sex transaction with a few clients who continue to patronize them. So we lost the benefits of many years of work with some sex workers regarding the COVID-19 pandemic. And we also noticed that the pandemic, the stigma around COVID-19 increased stigma around Cote as a person who are co-infected by HIV/AIDS and tuberculosis. So sometimes it's difficult to reach them when they are coughing and they are fear to be infected by COVID-19. In addition, we were faced with a general drop in hospital attendance, which had started to act the renewal of HIV treatment. We talk about the treatment as prevention, and for us, it's primordial to ensure continuity of treatment for people living with HIV, for key population who have treatment, for young person who have treatment. And regarding all this context, we set up a contingency plan against COVID-19 with our partners. And this plan allows us to protect community actors in order to relaunch prevention intervention, to maintain contact with people living with HIV in order to give them information on COVID-19, especially for young girls, for key population, and also to bring them back to the care. ARV home delivery has also been done to this population. We carried out awareness activities on COVID-19 combined with information on HIV/AIDS in the community. So for each population we target in our program, we know that for young person is very difficult to use normally the services we have, so we integrated COVID-19 information for them in all our intervention. We are currently developing a request to submit to the COVID-19 specific grant of Global Fund to allow us to continue and to strengthen this action. Otherwise, we like to integrate HIV screening and research station of chronic TB Cote in COVID-19 screening center with screen between around 2,000 people per day. So we have around 16 COVID screening center in Abidjan. So for us is to be able to integrate HIV screening and TB screening in this center. And at the end, I think the pandemic of COVID-19 has also led us to accelerate the digitalization of our work and approach. And it opened us possibility to develop application for young people, for young key population, and also application to follow person on treatment. So for us is, even if we have many difficulty during this pandemic to reach our population, our target, it was also an opportunity to work to strengthen our approach to digitalize, to make a digitalization of our approach and to better address the needs of some key population as the young and the men who sex on of another man who use many iPhone numeric tools. Thank you.
Thanks, Madiarra. So what Abhina describes as part of the problem, which is that everything has moved into the digital space and that opens up for blackmail and violence in that space, but there's also an opportunity. And I think we see that in many countries, that things that were being said were impossible for a long time, out of a sudden they seem to be working under COVID-19. And so there is an opportunity with this forced digitalization. And obviously you also spoke about the other opportunity of bringing together certain services like COVID and TB screening services in one place and really reaching a lot more people in with that. Thank you. Lilian, the same question to you, and maybe particularly around sex workers and adolescent girls and what the challenges are, but given the time where we're at in the conversation, really also talking about the opportunities that we're seeing, as much as it always feels a little awkward at a time when many people are really struggling with either COVID-19 or the secondary impacts of the epidemic and people dying. It always feels awkward to talk about opportunity, but I do know that we do need to do that. So over to you, Lilian.
Okay, thank you. And from what Abhina and Madiarra have presented, some of these things seem to be copy-paste. They're very similar. The challenges of lockdown, or at least restrictions on movement, have definitely affected our young girls and women, and also the sex workers. And just starting with the issue of the adolescent girls, those who are in school, schools were closed very early from March. Schools have been closed. So they've stayed home, resulting in exposure to basically sex, both consensual and non-consensual. We've seen a lot of cases of gender-based violence rising. We've seen an upsurge in teenage pregnancies that were unplanned, and people not understanding or explaining where that comes from. And we know that could be cases of both consensual and a lot of cases of violence, even within the home, by people known to them. We've documented a lot of these cases, like there was a curfew initially from as early as 7 p.m., meaning that those who live in slums trying to go to the toilet at night, which is outside your home, exposes you to predators. And we've had cases of girls who are raped in those kinds of settings. We've also had intimate partner violence because of partners staying in the same home with the perpetrator and the lady staying in the same home and then being violated because of now being forced in by the curfew and even loss of income. So that's a major challenge for the young people. Access to services was also restricted. We couldn't do outreach, and there were limited services, and there was stigma around going out or even going to facilities because people were afraid of getting COVID. So that also affected people's ability to access services. For sex workers, as has been explained, their livelihoods were severely affected because the bars were closed, the hotspots were closed, and the result was that they were forced to innovate and maybe go to clients' homes. And that resulted in increased cases of violence. We have a case of a sex worker who was killed in such an instance going to a client's home. So we know that's at risk, and those are the kind of things that we've been trying to advise against. But the innovation they came up with was coming up with new hotspots early in the morning. If the curfew ends at 5 a.m., then that's when the services would be provided. And they were able to deal with that. But in the same way, they were then more vulnerable to their clients and to violence and to the demands of their clients, like condomless sex or staying overnight, being paid a lot less, and that put them at higher risk. So we were able to try and really innovate around that. One of the things that we did was keep our sites open throughout, even if the services were restricted. We're seeing about 20% of what we would see every month. But by keeping them open, we saw people now starting to trickle in and really come and access services. And that informed us that the need was there. And for the adolescent girls and young women, we were able to use WhatsApp groups where we thought they would not access that. Even in rural settings, they were able to use WhatsApp groups to continue getting HIV prevention messaging and education sessions that they had before. And then we were able to then offer community outreach groups with clear social distancing, where we used to meet, say, 10, 20 people, would reduce it to 5 or 7. and make sure that they get their services. The peer approach also proved quite significant at this time, because the peers became the people we trained on COVID, in addition to the HIV messaging, to go and reach the beneficiaries so that they could really practice the prevention measures and address the needs for themselves. And were able to go and identify, especially sex workers, in their homes, because now they were not in their outreach. They were the ones who were able to go reach them in their different homes. We've also used this opportunity to monitor and collect data on what is happening, especially around violence, and collect cases and the evidence to make a case for what needs to be done differently. And community interventions have proved to be very effective, using community conversations and community groups to protect the girls and come up with shelters within the community itself. Those have proved to be instrumental at this time. The other key component is addressing the a hygiene pack, which covers things like pads, which we know are what really exposes young girls to sex, transactional sex. So you'd be able to provide a pack which included soap, pads, and food, which was the most urgent thing. And luckily, some donors were able to provide that. But even internally as an organization, staff did contribute to this effort, because we know how desperate our beneficiaries became. So we've learned that we can also offer 3 months. We were able to offer supplies of things like PrEP and ART for 3 months, as opposed to more regular follow-up, so that they could be able to have their consistent supply. And that also went to condoms, especially for sex workers. And that has worked really well to make sure that they're able to get their services when they need them and how they need them. And we keep our lines open. We've kept telephone contacts. We've used social media. We've used community health workers. We've passed messages through them, so that when the sex workers or the young girls need services, they're able to access them quickly. And we're able to even, for ART, we've even sent to people where they are. Some people were locked out of Nairobi, which was contained during the curfew. So we're able to courier to them, and that has also helped us to address this. Thank you.
Thank you, Lilian. Always amazing to hear about the kind of innovations and personal involvement that so many in community organizations and civil society organizations have had to adjust. I can never stop being amazed about all the that organizations have been making in this new situation. One thing that keeps on sticking in my head, and that I hear, whether it's around sex workers, women, Abhina also talked about trans and gay men and other men who have sex with men, is this issue around violence, and it comes up everywhere. It comes up in every society. Women's shelters are being overcrowded, lots of violence within families of sex workers, but even, all sorts of different forms of violence. And I keep on wondering, well, what else we can all do collectively to address violence, because it seems to be the Achilles heel of many of our programs, that people are facing such serious amounts of violence. I'll go to Ed for this question as well. And maybe Ed, if you can just talk about, in terms of what you saw as the Global Fund in terms of reprogramming efforts and the additional funding, where are the opportunities in this? Because you started us off on the thought of opportunities.
Thank you, Christine. Sorry, I couldn't unmute myself. So definitely the opportunities, acknowledging the challenges that have been raised, the opportunities again lies with the reprogramming process, which happens over the life cycle of the grant, as well as as I mentioned earlier, the COVID-19 response mechanism, the C19RMs. And these are opportunity for additional funding. As you know, the CCM already submitted funding applications for C19RM, or still in the process of doing so. For those that have submitted, I think we're going to go through again the process of grant making, and the input and suggestions definitely welcome to translate this funding request into COVID support programs. So we started to see that countries also leverage this plan and this opportunity to advance support for key populations and adolescents, girls and young women, in addition to protecting frontline workers and community from COVID. And we see that the funding requests on the C19IM that come in really focus on addressing the basic needs of key and vulnerable populations, particularly those who do not benefit from the social protection program. And I want to bring our attention here that this type of program could be supported. We see, for example, the case of Kenya, where the additional resources from this C19IM would be dedicated to addressing the financial security of female sex workers. So there's resources to support seed funding for female sex worker-led and people living with HIV-led groups. In Botswana, I think the support was requested to really ensure that basic services for undocumented migrants, key populations who can't access basic services. And the institution is engaging in this dialogue with the national government at the same time to ask them to better articulate how to make sure these efforts are becoming part and parcel of HIV support services to ensure sustainability even post COVID-19 or in the new normal. Secondly, what we hope to see more and more is the suggestions and requests to adapt service delivery. And as Abhina said, bringing the issue around intersectionality across key populations together and address them in the way that is people-centered. Because we often see how traditionally programs are really addressing siloed needs of each of the key populations separately, MSM, people who inject drug, trans, people in prisons. And I think we started to see some of the countries already proposing the program to adapting Frontline, the cadre of the peer educators, for example, in Costa Rica, where they're suggested to expand the cadre of peer educators for transgender to include trans who sell sex, recognizing that in this critical time, there's increased practices of sex work among this very group, and there's a necessary to really build trust and rapport for this group. Therefore, the program has suggested that the C19IM resources be used to really calibrate the peer educators to promote demand for services during COVID. And lastly, I think we want to see more and more funds being leveraged for innovations at the community level. And this is what colleagues on the call have been talking about. We see the innovations being proposed in Georgia, where they move all of the consultations, including provision of mental health clinics, support services for key population online. And similarly for Botswana, in line with our recommendations to really innovate human rights programming and interventions, to really use digital platform to engage with law enforcement agencies and creating a call center for reporting on stigma, discrimination, and gender-based violence. So I think those are quite promising, and these are the practices the community started to do and proposed that be adequately funded. And I think definitely opportunity during reprogramming and C19IM represent an opportunity to do this. And so my plea is definitely to strongly and proactively engage in the efforts to shape, implement, and monitor these additional modalities of funding and resources available and make sure it's properly implemented. Thank you.
Thanks, Ed. Really, really good kind of starting points for conversations around intersectionalities and innovations. And obviously, really important that we all document what we're doing in those spheres as communities and civil society programmers to make sure we're carrying that into a new normal, whatever that will be. I'm really conscious about time. I think I've done a bit of a crap job trying to keep us all on time, because we also want some question and answers, but you all have said so many good things that I couldn't just stop you. So just maybe as the last point to return back to, which is my favorite conversation, which is around political leadership in this momentum. So I want to speak, want to call on Paula, Gina, Ed, and Lilian, and maybe try to keep your contribution very short so that we can also get to some question and answer. So really, this is the question now about, you know, we know that there are huge challenges. We have heard about them. We know that there are resources being diverted because of COVID-19, not just financial, but also human resources. What do we need to do to position HIV prevention as a continued priority on the agenda of national governments, especially in countries where HIV prevention is furthest behind? I think you have all touched on it a little bit, but this is at the crux of the matter of how do we create different politics, right, at a really difficult time. So I start with you, Paula, but can I ask everybody to really speak for 2 minutes so, so that we really get back to some question and answer. Paula and then Gina on this question.
Yeah, thanks, Christine. What a rich discussion. For me, I think the best instrument for this really is the Global Prevention Coalition. It's a coalition that has as members 28 high burden countries. They together represent 75% of the burden, the global burden of new infections of HIV. So in addition to engaging with the focus countries on policy and on technical, technical guidance for prevention programs and on data, because data is important, we also engage at a political level. So for instance, in November last year, when we released the third GPC progress report on where the countries were along their prevention roadmaps, we invited not just the technical people, but the ministers from each of the member states. And this year as well, being 2020 and a pivotal year for the coalition, we are going to have a high-level ministerial meeting after we've collected monitoring, which you will also participate in, on where the countries are in honoring their commitments to HIV prevention programming and where they are in terms of their targets. So for me, this keeping the political momentum means engaging not just the technocrats in the country, but also the politicians and taking them along the way, showing them the evidence and the data, and having them commit to prioritizing where the gaps are being demonstrated.
Now I did it. Thank you, Paula. So now maybe the same question, Gina. Is the Global Prevention Coalition that place where we keep the political momentum and the pressure on to keep HIV prevention on the agenda and with the right resources?
So, as you know, the Global Prevention Coalition is undergoing a review of what happened. And one of the things that sort of come out of the review is that the data presented and kind of the dashboards of where countries are and comparing them to other countries is a real motivator for countries. And so going forward, I think it might be useful to think about those sorts of dashboards being expanded to more regional kinds of areas where more than the 28 coalition countries can participate, and then using those as jump off points for advocacy. So I do think that this data and someone looking at the data and trying to help countries think about the data is important. You know, what gets measured gets done, and if it's not measured, it's not done. So I do think that's one. The second issue is that after this sort of COVID lockdown, there's going to be a COVID recovery, right? And we're going to have to make up ground. And I think some of the data that Winnie presented earlier about what did we lose when prevention fell away? What happened? So, you know, so using that kind of negative outcome of stopping prevention as another advocacy point of view. And then we'll have all these other innovations that we really need to capture and really put into programs and advocate for beyond where they were innovated. I'll stop there.
Great, thank you, Gina. Lilian, what would you do? What would you say in terms of how we position prevention as a continued priority on the agenda of national governments, and maybe in your country, you know, in Kenya, what do we do to make sure that that happens?
Okay, so as mentioned, the issue of data is important to show what investing in prevention actually helps to achieve, and making it a real case, and using this COVID experience to show how by diverting resources, it has affected prevention or set us back. But for me, the other important aspect is the government has been very hands-on involved and provided leadership in COVID response. And I truly believe that if they did the same for HIV, we would achieve a lot more by 2025, not even 2030, and to show that they really can provide that leadership and the resources and channel a lot of coordination and support from across sectors, and not just leave it to the CSOs and a few targeted government departments to do it. Thanks.
Thank you, Lilian. And Ed, on the same question, what would you say to how we keep HIV prevention on the agenda?
Similar thought to other colleagues. I think it's definitely helpful to continue the mobilizations to leverage COVID-19 and bring attention to the issue about inequality and impact on vulnerability of particular segments of key and vulnerable populations, and make the case why such dedicated support is needed to be scaled up. And I think that's really critical. And for all of this, I think the Global Prevention Coalition partnerships and prevention advocates have a significant role as well to play in creating a sense of urgency to address the prevention needs of those who left behind. And perhaps we could leverage, the outcomes report of progress that's going to be coming out from UNAIDS to re-energize the discussions about prevention, document and share practices that work. I think the colleagues have already talked about it, as well as I see leveraging the funding mechanisms such as the Global Fund processes in terms of the funding for the last year of the implementation of the previous cycle. We still have a way to go and the way to influence the next funding cycles as we're now negotiating with the countries, as well as an additional funding mechanism, the C19RM. And all of this, we should continue to raise critical questions about the preventions and the focus on prevention or lack thereof, and really leverage that, bringing in people who are allies, who have champions that we have cultivated relationship over time through our HIV program, and have them speaking up in national forums. And lastly, I think it's important to capitalize this opportunity to really set up very ambitious programmatic targets, and not using COVID to compromise on our ambition to really provide prevention program at scale. So we know that the statement around the population size estimate for MSM will be coming out from technical partners to look at at least 1 to 4% of adult male populations being MSM. And we know that, we want to promote a method that's really enumerate the people who use online social media as a basis for program design for outreach. So all of these technical guidance that will come in, a stronger push for much more community-led program and a much more ambitious programmatic targets, I think would really get us there while keeping our eyes on human rights and the investment in community system, which is quite self-explanatory and demonstrative that in this time is the most critical component that needs to be funded. Thank you.
Thank you all. I might have to skip one question that we still had, which was, what to all the panelists, but maybe you put that into some of your answers in the question and answer session. What is the most important action that donors, civil society, and global institution could take to ensure that we deliver on the promise to end new HIV infections by 2030? So keep that in mind, because I won't ask you specifically on that question because we've run out of time. There's loads of questions there's several questions in the question and answers which are around adolescent girls and young women, and also women and HIV prevention, and pointing, I think, very much towards Abhina has been talking about, and I think Lilian also, about the fact that by making it sound like these are all the same, everybody's the same because we put them in the category of women or women and adolescent girls, we're not reaching people because there is so many intersectionalities and our services are not dynamic enough. So maybe I'll ask this one question and then I'll see who wants to answer it. There is a need to be more focused on various vulnerabilities of populations of adolescent girls and young women and how they intersect, in terms of other inequalities and discrimination. So for example, sex work, drug use, and how are we reaching young women and adolescent girls who might also be selling sex or using drugs, or are maybe not in are not being taken care of in mainstream adolescent girls and young women programs. I don't know whether, maybe to start with Lilian, maybe Lilian, did you want to say something on that? Or can you just lift your hands as the panelists if you want to speak to that point?
It's fine, I can
Just
start
go
on
ahead.
that. And I think it's a very important question, and it's true. What we've seen is it's a thin line between an adolescent girl who is involved in say transactional sex or sex work. And most of the time it starts with just basic coercion and the need for resources, but then gets into this cycle of sex work and eventually would be considered a sex worker because they'll go out into the streets and are taking care of their families. But in our programming, the challenge is, as I mentioned earlier, we still have that challenge of what does the guidance say, what is allowed, what is not allowed for those who are under 18, and how do you program for that? And we need to hear from their perspective, what are their needs? Why did they get into this? Would they like to get out, go back into school? And using a very client-centered approach to programming, as opposed to how we've been programming holistically with one set of guidelines and everybody gets the same package. So for the young people, we need to look at how do we address economic empowerment, you go back to school, preventing the sexual being at risk. We've even seen cases where we've tried to intervene and we might take girls back to school and they will stay in school, but in the evening they'll go back to the streets. So we need to be aware of that and really address the holistic HIV prevention, the broader SRH, so they don't get into pregnancy and the cycle continues. But we also need to start looking at how do we collect that kind of data and use it to inform our guidelines and programming and inform the changes in legislation and policy locally and internationally. Thanks.
Thanks, Lilian. I don't know, Abhina, if you wanted to say, your camera is off. I'm hoping you're still there. Whether you wanted to add anything to this question around, are we losing too many people because we're not dynamic enough? You know, the point that you spoke to. And when we speak about adolescent girls and young women, we don't consider them to be trans women or drug user girls who use drugs and so on. Do you want to add anything to that question?
Yeah, I think I just had a single point. I just feel that you know, this is an hour where you cannot have we cannot have a usual business. You know, our business has to be different because we are into the last decade of reaching to our SDGs, you know, and the UNAIDS goal and other related aspects. So one has to be dynamic enough. I think for that, the bigger role happens with political arena because the more the health ministers and other people are convinced, the more you will have diverse perspective in the field. So I think I will stick that is that yes, we do need to evolve in our programs, and we have to ensure that there's an advocacy which is not just an advocacy but an evidence-based advocacy to make that change happen.
Thanks, Abhina. I wonder if anybody, there's a very specific question to say, you know, we need to do much better in creating better prevention options for women. I don't know if anybody from the panelists wants to speak to that, because obviously we see that, yes, the biggest impact in new infections is in key populations, but in particular on women as well. I can see Abhina. Anybody else? Since I've given Abhina her word, but then go ahead, Abhina. You speak.
Yeah, can I just also highlight that
you need to put your microphone a bit closer. Yeah.
Can you hear? Okay. What I just need to highlight is that you know, from our HIV lens, I think our gender response is missing. And I just want to reiterate that because at the Frontline also we have been talking about gender inclusion and gender responsive programs elaborately. I think if we use the gender lens for the HIV programming, probably all these things will be addressed. Right now we are using a lens of an epidemic and not a lens of you know, a response to the communities. And that's a makeshift arrangement that we need to have it when it comes to the approach. I'll stop here.
Thanks, Abhina. And I see, Gina, you would like to add something to that?
Yeah, so I just wanted to say that there are, you know, products being developed as PrEP alternatives, longer acting PrEP as potential prevention for women. But I also want to point out that we don't need to forget the male partners. And at least in the sort of generalized epidemics of Africa, young men aged 20 to 35 are not treated. They're viremic, and they tend not to come in for testing, and they tend not to have viral suppression. So the other prevention modality for women is really trying to find and get those men on treatment, and having men use prevention also. So it's not all on the onus of women to protect from HIV. Again, that doesn't address the issues of pregnancy and gender-based violence and all the other issues for young women. But from an HIV prevention point of view, the male partner is also someone we need to consider.
Thank you, Gina. And I can see Madiarra also wants to add to that. And we're sailing very close to the end of the session. I haven't answered all the questions, but we'll just have another session one day. But Madiarra, please go ahead.
Yes, just to add on what the other panelists say, in my country, I show that we have a concern on mother-to-child transmission issue. Strengthening the prevention for women is also a strengthening of mother-to-child transmission. So for us, it's very important for young women, for women who can have a baby to adapt the prevention to them, to ensure that on the time need for them, they can have services on the language they can understand, and also engage the politics on SRHR issue also included in HIV programs.
Thank you, Madiarra, and thank you, in fact, all of you. If you were single, which I am sometimes, you would say, if it wasn't about women, then maybe we would have long found better prevention technologies to serve women, because we seem to, women, no matter in what shape or form we come, we are not first in the queue for many, many things. So let's just be honest about that maybe there have also been not the right investments in finding better prevention technologies for women. So, but that's a whole other seminar, I think. And as Abhina says, in so many ways, we have failed really to speak honestly and meaningfully around the gendered approach, or acknowledging the gendered impact of HIV in our programs. I'm really sorry, it is 3 minutes before we have to go, or 2 minutes. I know there were a couple of more questions. One of the questions, just to flag it, and maybe there should be a conversation, is one that often comes up, is where do the extra resources go to at country level? And is it always, especially with the Global Fund, is it always going into bigger civil society organizations that might not be as committed to building the capacity of smaller community-based organizations? But we can have a whole other seminar on that, I think, and we can. I think it's not a very one-fits-all picture or story, I think. So I'm sorry to the person who asked the question that I didn't get to ask the panelists about that. I think, just to round up, first of all, I want to say a big thanks to all of the panelists. I think you have done amazingly well in this format to try and be as interactive as we can be. You have all had lots of good interventions and thoughtful interventions about where prevention and COVID-19 meet and what that means for all of us at country level, but also at global level. It's obviously, it is worrying to hear again and again around the stigma and discrimination among people living with HIV and among key population, and that is a big barrier to access to services, and those services might not be available right now, and it's also a particular barrier in terms of COVID-19. I think we have heard lots of innovation stories, and often it takes years, but we have seen that out of a sudden, many things that we have all fought for a long time seem to be happening very quickly because of the circumstances. And I think many of you have spoken about how innovative people have been on the ground, and we do need to document that. I think somebody somewhere, we need to put a bit of time and resources aside and really document that, because we can't lose that innovation. And often it doesn't actually involve lots of technology. It's just doing things differently with in a different way. Obviously, we have a real problem around financing and where financing for prevention will come from. And I think there's not lots more to say. And I do think we still have a question around, what is that new politics that we need to create to really keep global health on the agenda, but to keep HIV on the agenda, and specifically to keep HIV prevention on the agenda. We had lots of conversations about the secondary impacts of COVID-19 and how that impacts prevention. And then specifically, and I hear that like almost on a daily basis, the issue around violence and violence impacting on prevention services, and something there that we all need to do collectively to do that better. I could go on and on. There are lots of points that somebody has put together for me here. I won't, because we have run out of time, but let me just say a big, big thank you to all of you for engaging in this way. I think apart from a first technology glitch, we have done quite well. So thank you for getting up very early. Thank you for speaking in English when you would rather speak in French. And thank you for contributing, and thank you for all the participants. And for the team that has made that possible. So watch this space. We'll find another way of continuing a really rich conversation. Thank you all.
Thank you.
Thank you, Madiarra. Bye-bye, everybody.
Thank you. Bye.
Bye. Bye.